So that's our 4 main reasons of why we would perform a hysterosalpingogram. Make sure you know these. The registry, as I said last time, has really been in love with this exam for some reason. Every person has been getting this on their registry for the past 3 years. So know it inside and out. Yes?
So whenever they have to choose one or the other, whenever you do, like you find out the gender or like the gender, like what does it show up as?
M and F. M/F. Well, in the order?
Well, yeah, or like
It says
blood test or
M/F.
Oh, so they don't like go thinking like, oh, it's a girl, and then make sure.
No, they put both until it's officially confirmed or decided. Yes. Yeah.
What about like the, I think they do a genetic test?
They can, but
What does it come out as?
if it has not been officially decided on by the parents, they're still going to leave it as both.
But in the genetic test, does it show up like XY or like X?
They can have that genetic test to help decide, yes, but if they choose not to, that's nothing up to the parent.
Would you say go by the genetic test or is it?
I mean, that's getting into some sticky territory. It depends on how you believe about that whole thing. Some people would say absolutely, some people would say no. I mean, it really just depends on what the parent decides. It's one of those, hot topic issues these days.
But in the genetic test, it won't show like.
In fact, I don't know if y'all heard, Texas Children's got sued recently for that.
No, what happened?
They were performing gender assignment surgeries without legality.
Mm-hmm.
That means they were doing sex assignment surgeries and they weren't supposed to, because the Texas you're not allowed to do that.
Question to be asked on that.
Where do you go for something?
Other states.
Oh, I didn't know that. I thought it was just like a, yeah.
It's per state issue. It's a per state issue.
Is it kind of
So
like,
TCH got in trouble because they were doing that behind closed doors. They got sued. Yes.
And what about like, so that was per state regulation? What about like national? If
What's the
something-
national law? I'm
Yeah.
not sure exactly on that. You might have to look that up yourself.
Okay.
Not 100% sure. Now, when it comes to like this with children, like if they have both organs, that's not the same as a sex assignment surgery. It's not like when they change gender, like gender change surgery. That's what I was referring to.
Reassignment.
Reassignment, thank you. Sex reassignment surgery. So they were doing that behind closed doors at TCH a few months ago, actually. I think it was a few months ago they got sued for that.
because if you sign off on all of it, why are you going to sue? Yeah.
I mean,
I don't know. Like I said, you can look up the story, but it was in the news a little while ago. We'll look that up. Okay, so moving on, guys. When we talk about the contrast media that we're going to use for hysterosalpingograms, it's going to be water-soluble, radiopaque contrast. It's inserted into the uterus directly via a cannula. So we basically kind of catheterize the patient in a sense, and then we're going to inject that contrast directly into the uterus. We also prep the intestinal tract. We're going to give them a laxative, cleansing enema, and meal preceding examination will be withheld because we want that, of course, to be empty of any gas, fecal material, or anything that might obstruct the organs of interest. So this will be a single contrast study, by the way, not double contrast. Single contrast study only for hysterosalpingograms.
Is Mr. Fong still here?
I think he went to clinic. Yes, I was just thinking that in my head. What salpingo stands for? I think it's for fallopian tubes. If I was to guess, because hystero is for uterus, salpingo I believe is for the uterine tubes, fallopian tubes. Y'all can correct me if I'm wrong, but I think that's what it is. Because you're doing this exam to look at the uterus and fallopian tubes.
To open the, if I'm not mistaken, it's when I did to open the tubes.
To check if they're open, make sure they're not clogged up, because they do get, in some cases they'll get, what's the word? Obstructed. Thank you, obstructed. And that's what we're going to look at here as we go through the procedure, guys. So for this exam, this is an important point, big star on this. Should be scheduled approximately 10 days following menstruation. Otherwise, we cannot do that exam. Reason being, the endometrium is less congested and it'll be least risk of irradiating a fertilized ovum if there has been conception that took place before the exam. Preparation will be to empty the bladder, irrigate the vagina, and have the patient cleanse the perineal region. Perineal region, make sure it's all clean. Otherwise, that's a very high-risk infectious area. So empty bladder, irrigate vagina, and cleanse perineal region. It's part of that prep. When we say irrigate, they're going to do just like this. They're going to stick this catheter in there and irrigate it with water.
So just flush it?
Hmm?
They just flush it?
They flush it out, yeah.
Your eyes look really blue, like I can't stop. Really creepy.
I think it's the jacket.
When I wear green or blue, my eyes get brighter. It's what I've always been told, so I'm sorry I'm creeping you out.
Stare at her hard.
Staring hard at their eyes.
More than usual.
That's what my wife says when I wear green and blue.
Oh, I thought you meant like
Bring the glasses back.
No, she says that my eyes get brighter when I wear green and blue, so.
No, my personal teacher was
Huh?
looked like my elementary principal. His name was Mr. Murphy.
For a second, I said Mr. Magoo.
No.
Like, what you trying to say, Mr. Magoo? Okay, moving on here, guys. So that's what it's going to look like under the fluoro. You can kind of see how tiny the organ is, actually. And what's crazy, look how tiny this is, and that's going to expand. I mean, I don't know how many times bigger, of course, when conception takes place. When you have a baby in there, it gets humongous, the uterus, to hold that entire baby. So for this exam, we're going to do a scalp image, usually just a pelvic x-ray, or bladder shot, as they call it. We're going to put the patient in the lithotomy position. You remember what the lithotomy position was? Mm-hmm. What's the lithotomy position?
Legs like this.
In the stirrups, right? Stirrups, correct. We're going to place the speculum into the vagina, then put the uterine cannula into the cervix, and then the contrast will be injected via the cannula. That will fill the uterus completely. And we're going to look for that contrast to flow all the way to the ends of those fallopian tubes and spill out into the peritoneal cavity. That's a good thing. We want that to happen. If we do not see the contrast spilling out at the peritoneal cavity, which is this area around here, that tells us that the fallopian tube is clogged up and not functioning properly. That can be fixed, but in some cases it cannot. It depends on if there's a growth, a tumor, something that's obstructing. That could be a numerous amount of conditions that cause that. But we do want it to spill all the way out. We want it to fill completely and be falling out of those little fimbriae, which we see right here. Here's the uterus, that triangular shape. Here's the fallopian tubes. There's the little fimbriae at the end. That's where the ovary would be connected right there. This side, here's the little fimbriae. That's where your ovary would be connected.
Why is speculum so big?
Because it is big.
But is that the ovary or what is?
This is the speculum,
No.
this is the catheter, huh?
Where the fibry is?
No,
Yeah,
that's the contrast spilling out, because you actually
Oh,
cannot
okay.
see the ovaries on X-ray, only on ultrasound.
How big are the ovaries per time?
They're pretty small. Yeah, they're pretty small.
So like where that little round thing is, that's the problem?
That's probably a good representation about how big it is, even though it's contrast, but
Oh, okay.
yeah, about that big.
So you'll never be able to see the ovaries on an X-ray.
No, just on ultrasounds.
Nor the fallopian.
Or you can see it on CT and MRI as well.
Fallopian.
Yeah, with the contrast you can see the fallopian tubes. And they're very, very thin, as you can see, very tiny.
Where are they?
Now, if you are seeing a large fallopian tube, that's actually probably indicative of the tube being clogged up.
Where's the fallopian tube?
So here's your uterus. Here's both sides of the uterus. See that little line? This is all fallopian tube. And then there's the fimbriae right there. Here, it's kind of, this is a little more curvy. Here's all fallopian tube right here. And there's your fimbriae.
You know, I always thought the fallopian tubes were just straight. Like,
Just straight?
Straight.
They're different on each person, actually.
Oh.
Yeah, they're not universally the same shape. Okay, so your images that you will take if you do plain films for this exam, single AP projection at the end of each fractional injection. And fractional injections are going to insert little contrast, insert little contrast, insert little contrast. Reason being, they don't want to just like squirt all that contrast in there all at one time. They actually could harm the patient, probably explode the fallopian tubes if you do that. So fractional injections to see that contrast flow all the way out in the peritoneal cavity, if everything's working correctly. Now, also why they want to do fractional is if they see that that fallopian tube is blocked, they'll be able to stop the exam and not keep injecting more contrast, which would make that fallopian tube expand like a balloon, which could pop. rupture. So other projections would be your obliques, your axials, and your laterals. That's other plain films if they requested, but as with all our fluoros, most of your doctors are just going to take fluoro pictures. They're just going to freeze the images and save them that way. You're not going to have to do the plain films, thankfully. So evaluation criteria for these exams: pelvic region 2 inches above the pubic symphysis, so make sure we get the entirety of the uterus, as well as those fallopian tubes. All contrast media visible, including any spill areas, and once again, the spillage is a good thing. That's not bad. We want there to be spillage. That means that the fallopian tubes are healthy. And then technical factors to show soft tissues and contrast media as needed. So I think y'all were asking, like, what happens to the contrast that's spilling into the cavity? The body just readily reabsorbs that through the blood vessels. It's not going to hurt the patient. It's a safe area for it to spill. I can quit yawning. I'm making me sleepy. It's only Tuesday. We got a ways to go.
Do you have a meeting today?
At 2:30, yes.
Yeah, I overheard.
Huh?
I overheard.
How'd you overhear? You spying on my office? It's an SLC meeting for International Day.
Didn't you say that at the beginning of
I did. I don't think she was in here though. Okay, so that's kind of what the exam looks like, guys. A couple more visuals for you. There's your speculum, opening up the vaginal canal. They're going to use this thing, it's called a hysteroscope. That catheter will be inserted all the way into the uterus. At that point, they will begin injecting that contrast in increments, just like you see right here. And we're looking for this to happen right here, full fallopian tube, and we want the spillage out of the fimbriae, which indicates the tube is open. What we don't want to happen is this right here, where we see this contrast is starting to build up, and we're not seeing the tube filled up. That tells us that the tube has been blocked, and at that point we want to stop the procedure because they need to go in there and figure out why it's blocked. Because if they kept injecting, of course, it could cause harm to the patient and rupture that fallopian tube. Yeah.
Well, what will cause the blockage?
It could be multiple things. Like it could be, the tube could be twisted, it could be a tumor, it could be ectopic pregnancy, deformities. It's a number of things that can happen. It's also why some females find out that they're sterile and not able to conceive when their fallopian tubes are non-functioning or like permanently blocked.
Could that endometriosis also cause it?
It could, yes. All right, so there's a few conditions you might see on a hysterosalpingogram. This is what's called a bicornuate uterus. What do you think that means?
it bifurcates?
Two uteruses, yeah.
Wow.
Two uteruses that are split.
I saw that on Grey's Anatomy, and she was actually cheating on the husband, so she had one baby from
Two
him,
different
and then
babies.
the other one.
I don't know if that's possible.
Was that the one with
but
the black
that makes a
baby?
good, that makes a good story.
No.
Yeah, I've heard it. Actually,
That's a
you
Mars
mentioned that. I've seen that happen, not from this, but I saw it happen in real life with a patient at TCH,
Oh.
where she had her husband's baby and a lover's baby.
Oh, are you
Both
serious?
babies were two different skin colors.
Wow.
And one had red hair, one had black hair, one had dark skin, one had light skin. Yeah.
Oh wow.
Ooh, that's
Yeah.
a perfect way to
So that's a rare condition where usually that can't happen, but very rarely you can have two eggs fertilized by two different sperm, and yeah,
just
At
nasty.
different times.
at different times. At different times, yes. They were with they calculated they were within days of each other when they were conceived. So
And they happen with the same person.
it can happen with the same person. Yes, it's very rare that happens, but it's possible. It's possible. Okay, this is another bicornuate uterus. Lateral view, apiaxial view there. In some cases, these uterus that are bicornuate are non-functioning, and in some cases they fully function as two separate uteruses. Just depends on the patient.
So does that mean you get like 2 periods?
I don't know if it means you get 2 periods, but Maybe.
Does it hold
I don't have it, so I can't tell you.
Double the fun, man.
Does it hold more
Yes. Urine?
urine? I mean,
Who said
what
urine?
is it? You said a uterus, right? Oh, my bad.
I hope that
There
doesn't
are
hold.
different holes.
I hope that doesn't
Tara.
hold
Don't
you.
you know this?
My bladder. My bladder. My bladder.
My bladder. Yes.
That was a good.
Damn, I lost it.
That was good. That was good.
I lost it. I'm sorry.
Lost
My bladder got me.
Walk backwards. It helps.
All right.
When I forget stuff, I walk backwards. It comes back to me. It really does work.
So you know how what's it called? Does it happen also like I think when you're surrogate or something like that?
Wait, what?
Like it has happened like when somebody's like surrogate or I don't know how you say that, but like they put the baby in your
Oh,
and then you
oh.
get pregnant with your, like your husband.
Yes, that can happen too.
Okay.
Very rarely.
If they have it.
Mm-hmm. Yes.
I remember. So would it make it more difficult to have an actual pregnancy?
I think it depends on how healthy each uterus is. I mean, some cases both work great. Some cases one is working while one's basically just useless. In some cases neither work. It just depends on how it develops.
Okay.
But at birth, you're supposed to give up both of the babies until they do all the babies and stuff like that.
Give up both the babies.
Yeah, like when you're a surrogate.
Oh, for a surrogate, yeah.
You have to give
Yeah.
both
That's
babies.
literally what
I know we're still talking about surrogates here.
So
Yeah.
will they have just
I
one
didn't write
cervix
it down.
though, or
Did I?
like it connects into one cervix?
One cervix that splits into two uterus. Yes.
Uteri.
Uteri. Uteri. Uteruses.
Uteruses.
So you mentioned that the surrogate parent, I've seen cases of that as well at TCH where the surrogate would give birth and would demand to keep the baby. Like they try to retract on the deal and cause like all this drama. Like I carry this baby, it's my baby. And yeah, I've seen a few of those end poorly.
How did it like they
I mean, well, I think they're bound to a contract with it. If I'm
Yeah.
not mistaken.
Man,
So
that's some
ultimately,
lifetime stuff.
That's why you have to go through an agency. Like,
ultimately it went to the family, but the surrogate mother would put up a big fuss and battle over it.
But no, it has happened like that. Like if the surrogate is having like they put the baby in their uterus and stuff like that, and then they get pregnant by their couple. Whenever the surrogate
That
gives
can
birth
happen,
to both,
yes.
she has to give up both babies, even though one of the babies is hers.
Oh, you're saying just give both up? Oh,
Yeah, she has
oh
to
wow,
give
that's
until they do the process of like
the DNA
DNA
testing.
testing.
I see what you're saying.
Oh,
Yeah.
okay.
That's interesting.
because like it's possible for a surrogate to have twins too.
Yes.
For you know.
Crazy
Two for the
stuff.
price of one.
Crazy stuff out there. Yes, two for the price of one.
It's that BOGO deal.
Special.
If you have a surrogate as a twin, it must be from the.
Well, that's what she was saying. They have to do like DNA testing to figure everything out.
It's possible that the surrogate can have two babies
Yes.
from the twin.
If they have
Yes.
like just like a regular baby.
This is what intersexuality looks like when they have both body parts.
Oh.
Let's see what we're looking at here. So,
Is this
bladder, uterus, penis. Right here.
One more time? Can you do that again?
Bladder, uterus underneath. Here.
Do they still have a period too?
Bladder, uterus, penis. This is a child, so
Oh, I was
this
wondering.
is like babies. So let's see. These are where they're just checking
The one
its
up
history,
here.
some pentagrams. So bladder, vagina, penis right here. So what they'll do is they will test both for functionality, see if one part is functioning better than the other. At that point, they'll present that to the parent and say, hey, the male body part is functioning better than the female body part. It's still up to you what you want the child to be, but we'll let you know what functions better, and they'll make that choice. And in some cases, both function perfectly fine. And so that's got to be a hard decision to make where you kind of just got to figure out, well, which one am I going to choose? Like, how do you make that choice? But
They're two
flip a
different
coin or-
places.
Huh?
I've never seen one, so like, are they in two different places?
Two different places?
Or like, how does?
Like, what do you mean?
Because you said the vagina's up there and the penis is down here.
Well, I mean, this is all, that, like, the vagina is going to go all the way down here. So there'll be a vaginal canal, and there'll actually be a penis as well. So you know all babies start out as female?
Yeah.
You know that? Okay, and then part of the female anatomy grows into the penis. That's how that happens. It's just like a deformity. Yeah.
And they'll put the correct sex on the birth certificate, right?
They will once they
Okay.
choose. Yes, until it'll just be MF or
Okay.
unknown. I've seen unknown written on the order sheets before too.
Would it then be possible for them to just leave it as is and grow like as a normal person, or like?
Yeah, I mean they can, but they'll be, I guess you call it a hermaphrodite.
Yeah.
Yeah, there's something. I mean, yeah, that does happen. They can choose to do that too.
Will their hormones be out of whack? Like they don't know what
Hormones, it depends on the functionality. So like if they have fully functioning testes and fully functioning fallopian tubes and ovaries, I don't know how that would work actually, because those kind of cancel each other out.
Yeah.
So
It's like
honestly, I'm not sure on that. I'm not sure. I am not sure on that. That's a good question. There's a research project for one of y'all. Y'all can present that at
So-
TSRT.
There you go. I'll take it.
It actually is kind of fascinating the way genetics work. And
I
all
searched
that.
one up, but it doesn't come out.
Oh, you're on the Harris Health Wi-Fi. Be
Is this
careful.
like a,
Yeah, be careful what you're Googling.
is this,
Might be taken to a hub.
like, is this topic
Huh?
could be used?
It could be used, yes. It's something we do in radiology, so yeah,
Yeah.
absolutely. It would be interesting.
Might say.
Question?
I have like now that we've got like genetics sort of question. If both are fully functioning, then could they technically clone themselves?
Clone themselves?
Yeah.
Fertilize themselves.
I have no idea. That's a good question, though.
Not my
I was like,
project.
I only teach this.
I don't know.
Melanie, there you go.
That's beyond my scope of study, but that's a good question. Good question. All right, final image before we get on to the spinal cord. This great image here. In fact, this is such a great image. I would put a big star on that image and memorize that image because you may see that again. This is bringing out those parts of the uterus and the fallopian tubes. Starting here at the fundus. Y'all remember the other three parts of the uterus? We had this fundus,
Body.
and let me just point these out to you. Fundus is this triangular portion right here. Body.
Oh,
What was the next part?
Cervical.
Isthmus and cervix. The cervix, isthmus, body where it curves, and the big triangular portion is the fundus. Now, what was our other parts? We have the isthmus of each fallopian tube, the mid portion being the ampulla, and where you see that big curve with the fimbriae, that's where the infundibulum starts. Infundibulum.
And then what's after the infundibulum?
The fimbriae.
The fimbriae. Okay.
Fimbriae.
And then move that long and squiggly.
Yes, they are. Like I said, it's shaped different for every patient, so it's not like a universal
is one longer than the other?
look.
Yeah, this one was longer.
I wouldn't say they're longer, just like parts of kind of superimpose on itself as it's kind of curly queuing around.
You know, like your kidneys, like one's bigger, the long one's
Yeah.
like, it's
Yeah.
one longer than the other.
So would that also, like, depending on how torturous it is, could it be a like obstruction of sorts? If it's just too
Oh.
coily,
If it, like yeah, it could what's the word?
torturous.
Like a stricture almost, like a narrowing.
Oh, stenosis.
Not what's the word for twist? We learned that. What's the twist thing? The volvulus. Thank you. Wow, I just cannot remember that word. Volvulus. Yes, that can happen. It'd be like a birth defect. Oh, we had a few more examples. I'm sorry. So a few more. We're not going to go into as full detail on these because they don't ask about these as much. They mostly focus on those hysterosalpingogram. So we have pelvic pneumonography. What's the key factor of that word?
There.
Air. So they're injecting air for this exam. So radiologic examinations of the female pelvic organs via intraperitoneal gas insufflation. That's a fun word. Insufflation. They're going to insufflate the uterus. That's what we call pelvic pneumonography, gynecography, and pangenecrophy.
Pangenecrophy? What?
Pangenecography. Oh, how you-
Necro means dead.
Pangenecography.
Yeah.
Yeah, replaced mostly by sono. These have become relatively obsolete because of ultrasounds. They still want you to know what they are.
So, gynecography.
They pangynecography. Pangen. I don't know why I'm trying to say Pangea, like pangenography.
Pangea.
I don't know why I'm talking about Pangea. Okay, so then there's vaginography.
Whoa.
Vaginography. That's used to investigate congenital malformations and primarily for those fistulae we talked about. And what are fistulae again? Connections, correct. Bad connections. So it'd be a connection of the vagina to the intestines, for example, or to the bladder, causing those waste products to end up in the vaginal canal, which would cause a lot of infection and or toxicity to the patient. So contrast will be introduced via, yes, a rectal retention tube. Doesn't go in the rectum, but they use a rectal retention tube. Under fluoroscopic control. And after the images are made, the patient will be asked to expel as much of that contrast as possible, to push all that out. Then it will be irrigated if there's any residual contrast. So main thing to remember on this, guys, is done for malformations, congenital malformations, and fistulae. I have never seen them do this one either. I think they're just going to usually opt for that hysterosalpingogram over anything else. It kind of covers all the tracks. Okay, that's what it looks like from the side. By the way, great example here. This is the vaginal canal. Look what we're connecting to. Ileum.
Ooh.
We're connecting to the ileum. So that waste product from the ileum has a chance of leaking into the vagina itself, causing massive infection and major issues for the patient. So main thing that we're looking at for evaluation criteria, guys, any fistulas in their entirety. Any fistulas in their entirety. It's obviously very dangerous, a very dangerous condition.
Could that cause sepsis?
It could, yes. Toxicity, infection, yes.
I don't understand what means by any fistulas in entirety.
Any fistula? You want to see the entire fistula. So that's the pathology that we're mainly imaging. This is a little connection, so we want to see the entire connection. That's what that's referring to. Oh, by the way, it's also connected to sigmoid. I don't know if y'all saw that. Ileum and sigmoid. So we're getting small intestine content and we're getting sigmoid colon content in there. Kind of gross. I know y'all are not packing up this early.
Wonder how they found that out.
Okay, okay. I think y'all give me anxiety when y'all do that. Start packing up while I'm trying to talk.
It's 2:25.
Sure it is.
Don't get anxiety.
It's good to have positive energy like that. Just keep telling yourself it's almost 2:20.
Guys, it's only 1:30.
It's almost
Good
May.
energy.
It's almost May 2020.
We got
Now we also have pregnant patient procedures. These are done as a last case scenario, or if the fetus has been confirmed to have passed. These are the only reasons that we're going to do these. So ultrasonography, obviously the preferred imaging modality because of the danger of radiation, but they may ask for a fetogram to image the fetus in utero if there's a danger to the baby, like if the baby is dying or there's some kind of fracture, like let's say they got into a really bad car wreck and they're afraid that the fetus might be damaged. They may do one of those abdominal x-rays or fetograms, or once again if they confirm that the baby has passed. They can also, let's see, determine the presentation and position of the fetus to see if it is sitting correctly. Is this baby sitting correctly? Absolutely not. What is this called? What would this be called if they gave birth like this? A breech birth. Feet first, y'all see that? Head's up here. Where's the head supposed to be? Down here. By the way, maybe I'll know something else about this radiograph. As far as no one's mentioned it yet. Did you say twins? You're correct. There's a head, there's a head.
Oh, I thought it was just
This baby's spine, you can't really see this baby's spine very well, but it's the way this child's laying. So that's like double breech.
definitely.
So how do they confirm feels dead from the image? Like,
Is it
So
her
they
heartbeat or
don't.
something?
So they don't. They say confirmed death, but really they do ultrasound to confirm like heartbeat. But they'll basically just do like
really, they're just trying
what's
to
the
see the
word?
position.
Almost like an autopsy kind of X-ray, like before the baby's passed, before the past baby has passed. I had to do a few of those X-rays in the morgue.
Like the whole mom back
It's stillborns and stuff. Yeah.
Oh.
Yeah. So when a child dies in the womb, it'll be passed. The Bible pass it out, and at TCH we'd have to go in there with the portable and do an X-ray of the baby after it's been passed. And it's as horrible as it sounds. It is as horrible as it sounds. I just always told myself they're baby dolls. They're not real, but yeah, it's like it's part of the autopsy process to get an X-ray of the baby.
Okay, so it's just there, or like every other hospital?
Sure, that's every hospital. Yeah.
What do you take? Like, what kind of X-ray?
Like a whole
They'll just do a
body?
full AP and a full lateral.
So you have to
They
go in there.
they do it.
Oh.
They do it.
Like the
I wasn't
morgue
touch.
people
No,
do
I
it?
wasn't. No. I mean, yeah, the morgue people do it for you. Yeah.
What do they do with like
The corpse
the waste?
depends on what the parent wants to do. They bury it or they cremate it.
They
It's up to the
don't-
parent, or donate it to science.
Okay, so that's when they would take like stem cells and
Donating
organs
is
and.
fine.
Some people do that. You can donate your body to science. In fact, you know what? I've decided whenever I pass, I won't be in the Body Worlds exhibit. They're gonna put my corpse up there on display. You ever seen the Body Worlds exhibit?
You don't want to come back to Harris Health as.
In fact, y'all can put me in this corner right here in a glass case.
Always so nobody breaks him.
That is a real thing, by the way. If you ever get a chance to go see that exhibit, it's a really cool exhibit. Body
That's
Worlds.
what you
It's
say.
like real cadavers that have been
marker, he comes out.
plastification. They've still been a plastic. It's Body Worlds. It comes to the Houston Museum every once in a
I
while.
went one time, I got to hold a liver.
It's really
and a
cool.
lung.
It's really
Oh,
cool.
Awesome.
Anyway, you can at the end of that exhibit, you can sign to donate your corpse to be plastificationized, whatever it's called. Cool stuff.
They have like their
And that's how Tom Cruise stays so young.
Then we have pelvimetry. That's going to be an exam that you just need to know what these are for these last two. Demonstrates the architecture of the pelvis compared with the size of the fetal head and determines necessity for a cesarean section. But usually I kind of already know that anyway. Placentography is going to demonstrate the walls of the uterus to locate the placenta in cases of suspected placenta previa. It's going to be your placentography. Placentography. I'm trying to remember what that is. I'm sure one of y'all are going to ask what's previa. I'm trying to remember what that is. It's
yeah,
escaping.
it's when the uterus, is that when it's coming first?
I think so.
Yeah, I think that's when
so.
the placenta detaches from the wall and it's like trying to come out
Almost
first.
like prolapsing out. Yeah.
Placenta lies very low into the uterus and covers all the part of the opening of the cervical.
There you go. Okay, so for males, much less interesting. They're just going to go to ultrasound. That's all you got to know. Why would they go to ultrasound for these exams? To look for cysts, abscesses, tumors, inflammation, and sterility. Ultrasound is the most common and the gold star modality for all male reproductive procedures, unless you have a few cases like I did where you got to do like a soft tissue penis x-ray because someone almost severed it. I told y'all that story. The guy getting stuck in the bottle and tried to cut it out. I didn't tell y'all that
I
story.
thought you said that was you. I was like, wait a
Yeah.
minute. No. It's the way you said it. You started the sentence off. and that's what I did.
He said it's the one I did. He said it's the one I did.
Oh my
I already told y'all that story.
I'm just like.
What happened was
Okay, I'll give a. This is when I was a student. This was one of my first 2 weeks as a student, as a matter of fact. This guy, this old man, this is Louisiana, by the way, so you can judge all you want. This poor elderly chap, he was driving down the road, middle of nowhere. There was no place to stop to go to the bathroom. He had a glass Coke bottle, so he proceeded to pee in the glass Coke bottle. I don't know how far he put himself in that bottle, but he got stuck in the bottle. So instead of going to a hospital, he proceeds to go to the next Walmart and purchase a razor blade and cut the bottle off. And in the process, nearly cuts himself completely off.
Oh my God.
So we saw this order come through on the machine. You see this order come across on the machine and it says soft tissue penis x-ray. And me and the tech are looking at each other like, what? That doesn't even exist.
Is this at the place where like only like 3 people come through the whole shift?
Yeah. Yeah, that was our fun-filled night. 'Cause I was working at a night shift as a student that particular rotation. We had night shifts at my school.
Oh.
Anyway, yeah. So it's just like it sounds like. Did a PA and lateral soft tissue penis x-ray of what was still attached. Because they wanted to see if they could reattach it
Could they?
correctly. I think they did reattach it, but he didn't have any nerves left in there, so
Oh.
yeah. I mean, it's still
Oh,
through it.
not pointless. No.
So
Which one's the?
you never know what kind of X-ray you're gonna get. They just make up stuff sometimes. That was the first and only time I've ever done that before. That was interesting.
How do you figure out which one's the
What did the
PA?
text say? Like,
How do you figure out which one's the PA?
Yeah.
Do I have to explain?
No, I'm just curious. Yeah.
John, make him explain.
No, it's okay.
Okay, you put it like this on the cassette for PA. You put it like this for a lateral.
Lateral.
Like a finger.
That's
With-
AP though.
Yeah, that's AP.
That would be AP, you're right.
Because PA, you'd have
Don't
to
put
be
the
like,
guess
You gotta flip him upside down.
Yes, it would be AP.
Hey,
You gotta do a handstand.
He's like, look, man, I was just playing with that man.
Okay, so it's
Hey,
AP
hey,
and lateral. There
hey,
you go.
playing with
AP
that
and
AP,
lateral.
and that's awesome.
Yeah,
That's that patient care. That's that patient care.
Yeah, so
It's like I did what I had to.
that would be the only case where you might do something out of the ordinary for the male anatomy on an X-ray, soft tissue purposes. That's the only time I've ever seen that, ever.
Was he powering your pain?
He was surprisingly
You know how
calm.
Alice started
They
this
just-
morning?
Yeah, you did see
I felt sorry for him. He was like 80-something years old, really frail, just this nice old man. I felt bad for him.
He was probably excited that he could get sex still.
I mean, you would probably get olive oil or something. Get some oil or butter or something. I mean,
Or just going like.
I don't know why you're gonna purchase a razor blade and try to cut the bottle off.
It was cheaper. He only had 20 cents.
Evidently, or break it.
How
But
do you
then that
walk in the
might
store?
risk piercing yourself.
With the
How did he walk into Walmart? Is my question.
Because you were gonna cut the
Well, just go to the
John,
hospital.
you
Just go to the hospital. Moving on, we have what's called a prostography. Prostate. I cannot say these words today. Prostatography.
Prostato.
Almost like potatography.
Prostatography.
Prostatography. That is what it sounds like, a sonogram for the prostate. That's all you gotta know. It does look like a peach.
That looks like a heart.
It's actually compared more to a walnut, actually, in size and appearance.
Oh, that's small.
It's more like a walnut.
That's small.
It's about the real life size to a walnut.
Okay. I suppose.
Should we call him back?
What about macadamia? What's
If that works better for you, macadamia nut.
it? Don't.
Choose your nut. today.
Walnut it is.
Okay, so for review questions, let's wrap up this reproductive chapter because I don't know where we're going in this class. Hysterosalpingogram may be performed for what, guys? What are the reasons we do hysterosalpingographies?
All of the above.
All of them, all of the above. So for lesions, polyps, tumors, size, shape, position of the uterus, and also for patients that cannot conceive. And what's the only one that's missing from up there that we talked about? When they have two parts?
Oh, bicornuation.
No. Intersexuality.
Oh,
It's called intersexuality.
Wait, should we do an HSP for something that they could see?
Hmm?
You said if they have two parts.
If they have the uterus, they're going to check the uterus as well.
Oh, okay, my fault.
Which of the following procedures is used to investigate congenital malformations in vesico-vaginal fistulas?
See.
Correct. C, vaginography. That's the main reason we do that exam, for fistulas and malformations. Which one injects air?
The B.
B, and which one's for babies? Fetography.
KUB.
Which exam can be performed on a pregnant patient? I think I just gave you that answer. Fetography. And what term describes the investigation of the prostate by radiographic, cystographic, and vesiculographic procedures?
Dang, I don't know.
Potatography, right? That helps. Potatography. Prostatography. Okay, so now we're on to chapter 14. This is going to be myelograms. So when it comes to myelograms, the anatomy revolving around the brain and spinal cord can be quite complex. You can breathe a sigh of relief because we're not going to worry about that brain stuff till you get to CT. When y'all come back and visit me in CT, we'll learn all about the brain. But we've already talked about the spinal cord structures, of which there aren't too many. and that all-important subarachnoid space that surrounds the spinal cord as well. It's our main stars of our show. So there you go, guys. There's the definition for a myelogram. Radiographic study of the spinal cord and its nerve root branches that uses a contrast medium. And some of y'all have seen these, or partial myelograms, because they do a lot of spinal taps at Harris Health. It's not a full-on myelogram. It's kind of like the first part of the myelogram that you're seeing. A full-on myelogram would be completely injecting that contrast into that subarachnoid space, having the patient move around, getting an analysis of that full spinal cord and the space surrounding it. What y'all are seeing mostly are spinal taps, which if you do a myelogram, a spinal tap is required beforehand. Reason being, or if you, I want to ask you, since y'all have observed and participated in these, when you do those spinal taps, what's the point of getting that CSF?
To confirm that you're in the space.
That's one reason, but what else?
Infection.
Huh?
Infection.
Infection. How do we know there's infection?
You send it to labs. Yeah.
But not only that, we can also visualize if there's blood in the CSF. That's usually indicative of an infection. If there is any kind of infection at CSF, we're not going to proceed with this exam. It would be too dangerous. Yes.
Would it also be noted by like color? If there's a color present?
The color, yeah, if that's very strong color, usually that's indicative of an infection as well. Kind of like urine, if it's like too dark.
It's supposed to be clear, right?
It's supposed to be clear. If it's cloudy or bloody, usually that's a bad sign.
So you said if it's like cloudy or bloody, you wouldn't do it?
You would not. You would not. It'd be dangerous to the patient. Because that CSF travels all the way up to the brain, we don't want to infect the brain and kill our patient, essentially. Okay, so what are we talking about with CNS, central nervous system? That consists of the brain and spinal cord. Don't worry, you don't need to know all the parts of the brain. Just come visit me again a year from now in CT. We'll talk all about the brain and the medulla oblongata and the pons and the other stuff that I can't remember off the top of my head. No pun intended.
Cerebellum,
Corpus callosum, cerebellum, cerebrum, gyri, sulci. Yes? No puns intended. There you go. See, I love this class. Okay. So there we go, guys. We have the brain and the spinal cord. But the main area that we are focused on for these exams is this subarachnoid space. It does not mean that you have spiders in your spine. No one got my joke? It's Halloween. Come on. Y'all know what arachnids are, huh? Subarachnoid space doesn't mean you have spiders in your spine. It's the space that contains the CSF surrounding the spinal cord. We have a couple of parts to make note of. The conus medullaris. Y'all asked what my favorite word of this section was. There's my favorite word. Conus medullaris. I like that one. That's the end or the termination of the spinal cord. Now, contrary to what people think, the end of the spinal cord is not down in the sacrum. It's actually at the level of L1. L1, that's a great thing to remember. You can write down, put a star on, know for your registry. The spinal cord terminates at the level of L1 via that conus medullaris. Also, very important puncture site. That is the most common site that we use to draw out CSF, and you should know this if you've done these at Bentab or LBJ. That's going to be the L3, L4 space. That is the most common, not the only place, but the most common place that we're going to draw out that CSF. Why do you think that is, by the way? Why do you think that would be the most chosen place to get CSF?
And where? L3?
Not a trick question.
When you say it? L3, L4?
Why would L3, L4 be an ideal place to get CSF?
That's where you get them epidurals and stuff at.
That's where you get epidurals, but that's not why we use that for lumbar punctures, spinal taps.
Oh, you can feel
Because sorry, go ahead.
Oh, no, go ahead. I'm sorry.
The spinal cord itself is higher, so you're not...
Correct. So look, here's your spinal cord ending at L1. What would happen if we tried to get CSF up here? We'd be at risk of doing what?
Paralyzing
The patient. It's very dangerous to do so. Now, in some cases, they do get fluid in those areas. That's like a last resort. This is the safest spot to get that CSF. There are some nerves you gotta look out for. You see all these little lines? Those are all nerves traveling down, but less of a risk to get that CSF from that area, which is why you're so important with your fluoro machines. Make sure they're putting that in the right spot. I would hate to work around the spine. I'd be scared to death to do that as a doctor. So many issues can arise and happen if you don't do that just right. All right, talk about the spinal cord. Let's talk about some of the parts of the spinal cord. It's a slender, elongated structure that originates at the brain and terminates at L1 or approximately L1, L2 space, according to your notes right there. We have what's called the inner gray cellular substance. This is an axial view of the spinal cord, and an outer white fibrous substance as well. Then we have a gray substance that forms an H shape that we see on the transverse section right here. So you have your gray matter, you have your white matter, that's all part of your spinal cord, same as how your brain has gray and white matter, same thing. And then we have that conus medullaris, that's the termination point, once again, of that spinal cord at that L1, L2 space. By the way, where does the spinal cord travel down through our vertebrae? What specific hole that we learned in Rad Pro 3? Not the intervertebral foramen, that's for your vasculature.
The magnum foramen, yeah.
That's where it comes out of the skull. But where does it go through down our spinal column? Thank you, vertebral foramen. The vertebral foramen, big round hole. The vertebral foramen, that's where the spinal cord travels down. Yes. Oh, sorry. Whoa, how far did I go?
I don't know.
Holy moly, okay. Here we go. Yeah, conus medullaris. There's another word I love, cauda equina. Such a pretty word. We'll talk about that. And filum terminal. I got some. Oh, I love this chapter.
Oh.
We got the conus medullaris, the filum terminal, the cauda equina. Just pretty words. I like those words.
Is that because it looks like a horse's reins?
Yeah, that's it. That's what it's.
I've never thought of it that way, but maybe,
That's
yeah.
what equine means.
Yeah, equine is a horse. I've never thought of it that way. So filum terminal, that's going to be the delicate fibrous portion that connects the terminal tip to the first coccygeal segment. So it's a fibrous connection, filum terminal. 18 to 20 inches long, connected to 31 pairs of our spinal nerves. That's how you walk, talk, think, blink, eat, sleep, poop. There you go, those spinal nerves. As my kids would ask, eat, sleep, and poop. It's like eat, sleep, and poop. They arise from the roots on each side of the spinal cord, transmitted through the intervertebral and the sacral foramina. So those intervertebral foramina y'all just talked about contains those spinal nerves. It also contains vasculature that travels all the way up to your brain as well. Then the cauda equina is just a fancy way of saying your spinal nerves all together. The cauda equina. You get on my cauda equina. That's a great way to confuse your family at Thanksgiving. Y'all get on my cauda equina. My sister would give me the greatest.
Lily moment.
That was a Lily moment. I was gonna say, okay, Lily, you can at least pretend to laugh at my joke. My sister would give me that look too if I use that joke at Thanksgiving.
I forget you're not another child.
No, I'm not.
Just y'all two?
Hmm?
It's just y'all two?
Just us two. She's 3
And
years
your wife?
younger. 3 years younger than me. Huh?
And your wife? She has one sister?
My wife has a sister and 3 brothers.
Oh.
She's the oldest.
Oldest of them.
I'm the oldest too.
Well, yeah, you just said it.
Yeah.
Yeah. He's younger than you.
I did say that, yeah.
This context clues are killing today.
Okay,
When
meninges.
was the film doing this?
Filum terminal is the fibrous portion. So right where that conus medullaris is, there's always little fibers coming down. That's the filum terminal.
And that's 80 to 20 inches long.
Hmm?
That is 80 to 20
Yes.
inches long.
Yes. By the way, just like the Water Boy, the medulla oblongata. Have you ever seen the Water Boy movie? That's what he's screaming about in that movie.
That's what Mama always said.
His mama always talked about the medulla oblongata. That's where orneriness comes. Orneriness.
That's where it comes from.
Orneriness. Can't say the word. That's why alligators are so ornery. In Mars, medulla oblongata.
That's what Mama said. What part of Louisiana they was supposed to be in? I'm forgetting.
That was,
Baton Rouge.
I think it was made up. I don't think that was a real
It
city.
was made up, but I just
I think it's supposed to be around New Orleans, though.
Yeah.
Yeah, that's
Weird.
New Orleans.
Nolans.
Nolans.
I'm gonna be traveling to Louisiana in about 4 more weeks for Thanksgiving. By the way, great reason to go to Lake Charles. Chef Ramsay's opening his restaurant next month there at one of the casinos, the Gordon Ramsay Steak. I'm gonna save up my money for a whole 2 months to
So you can get some fries.
So I can get some fries, yeah. I've always wanted to try the beef Wellington, so he's gonna have the beef Wellington on the menu. So for real.
Okay.
Yeah.
I guess I can.
Okay, so meninges. We're going to talk a little bit about the brain, but not too much. We have what's called 3 continuous protective membranes that enclose the brain and the spinal cord. That's our meninges. We have the pia mater, but not pia mater. It's pia mater. That's the inner sheath, highly vascular, and closely adhered. Then we have the arachnoid, which is the central sheath, and then the subarachnoid space. That's the one that we're mostly concerned with, because that's where we get our CSF. That's the wide space between the arachnoid and pia mater. And it goes from the brain all the way down that spinal cord, all those layers. Pia mater, arachnoid, and subarachnoid space. We also have a dura mater. We're not going to talk about that until we go to CT. You like how I'm saying that? Y'all all coming back to CT. I'm already stating it as is. We'll talk all about those layers in better detail.
Should I apply now?
Yeah, go ahead.
Or you're gonna set those?
Yeah, that's
No, they're gonna take your
For
money.
CT, yes. For MRI, it's a lot more competitive because you have to have more tenure under your belt, typically, to get in.
Thought it changed it for you.
CT, you can accept up to 30 people, so
How many y'all get?
it is not too much.
I'll take CT over MRI.
MRI puts me to sleep.
I feel bad for this one.
You learned that from Miss Bonilla?
No, I said I kind of feel bad.
Oh. Okay, so for CNS imaging procedures, we have our typical regular radiologic examinations. That would be like our typical L-spine, T-spine, C-spine. They fall under CNS, central nervous system exams. We have our myelograms. Of course, speaking of CT and MRI, those also count as far as CNS procedures. And then interventional, very heavily involved with CNS procedures, as those of you going through IR have probably already seen. IR is just getting so much more popular too. It is really blowing up. I really have this fear. I don't want to be a Debbie Downer, but I have this fear that the ART is going to be going like this, like money, 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 and start requiring that be a separate modality. That's what's being murmured right now. It's not just me thinking that. I hope they don't do that, but they see it as a cash cow opportunity. Who? I saw him this morning. He came in the room and said, "Hey, Dad, I've been missing you." He came and give me a big hug.
But so the people that are already in there, they're like they don't have to take those tests.
If they're already in there, they're grandfathered in. As far as I know, yes. But I don't know, they might make them.
What test?
They might make them at least like apply for a license. Like pay for a
That's fine.
licensure.
I'm just trying. What?
Well, you know how like MRI is a separate modality, but now like MRI and CT, you have to go to school for it and get.
I'm saying, I have a theory, and just from murmurings from my connections I have throughout the organizations, that they're going to try to make that into a registry as well.
IR already has a registry. It's called the VI.
I mean, like a full national ART exam.
Oh,
is
I see,
what I'm
okay.
talking about.
Like in order to get it.
Yeah, like actually have like an actual modality
I see.
certification, which would be crooked, but I wouldn't put it past them. Crooked. As my grandpa used to say, that's crooked.
Because you know how like they'll do CT in there too. So would you have to do X-ray CT and then?
That's a good question. You might, I don't know.
Like if you do IR, can you do CT with it together?
All I can say is that if they see the dollar signs, they're gonna run to it.
It's all about the money.
That's all I get in there before.
I don't have very many nice things to say about that ART.
Ooh, I'm gonna tell Brandon.
Brandon's on ASRT.
Oh, true.
Brandon's doing great with ASRT. He's trying to fix all that kind of stuff.
Was that the guy that was on graduation?
Mr. Smith.
Yeah. Brandon Smith. Huh?
You heard what she said?
What'd she say?
She said, I said radiation, the IR is too much radiation.
It is a lot.
She said, yeah, that's the only thing that's holding me back. She was like, because I'm really young. I said, I'm still young.
You know what? Age,
Trying to throw that thing at me.
age is only a number. How young you are is a mindset.
Oh, that's kind of scary.
I'll just leave it at that. Okay, so radiographic exam may be used to demonstrate bony anatomy. We're talking about CNS exam still. Looking for trauma, pathologic changes, degenerative conditions, and post-operative changes. These should always be done before contrast procedures such as myelograms to look for any kind of fractures and or issues going on with the CNS system. If there's some kind of major fracture going on, they're obviously not going to do a myelogram. It could be way too dangerous. It could actually kill or paralyze the patient. So typically your regular x-rays will precede any of these myelograms or fluoroscopic procedures, obviously. Kind of like doing scalp images. So your L spines, your T spines, your C spines, those will precede these exams to check for any kind of injuries or trauma. Thank you for going back to your seat so I can find you now.
You're targeted by the
It's like that running joke. My wife always, she always gives me a hard time. Like, I have a spot for everything, including y'all. Everyone has their spot. It's how I find you. But my keys, if they're moved like 10 inches to the right, I can't find them. My keys have a spot. If they're not in their spot, I can't find them. That's how all my stuff works. All my stuff has an exact spot. I'm a bit A-type like that, but I can't find it. Like, it's like 2 feet over and I can't find it.
Guys, we know what we're doing.
So there you go. You want to prank me? Just move my stuff over a few feet. I probably won't
Just
find it.
rearrange your entire office.
Oh, please don't do that. You know, we talk about mental health crisis.
Hey,
Don't do that to me.
Senior prank day?
Don't do that to me. Don't do that.
You sure do.
Yeah, I mean, last class went to
I already got 3 kids that do that enough at home, so don't do that to me here.
Wait, this is, what are you at lab?
I'll go to my office at home and be like, who's been in here touching my stuff? Which one of you 3's been in here touching my stuff?
All of them.
It wasn't me, not me. I'm like, this is not me person. I'm gonna find this not me. Not me is very guilty of a lot of stuff. If y'all find not me, please report not me to me.
I was the name Lily.
This is giving rush hour vibes.
She usually is the guilty party, typically. All right, myelograms. What's our clinical indications? HNPs, tumors, cysts, and of course trauma such as bony fragments. To make sure that those bony fragments have not punctured that subarachnoid space, causing CSF leakage. And that can be a very serious dangerous, possibly causing death condition if we have leaks of that CNS. Contraindications, like I already told you, why we would not do a myelogram: blood in the CSF or cloudy, dark colors. Arachnoiditis, what is that, swollen spiders? What is that? Inflammation of the subarachnoid space. Increased intracranial pressure, what could that be? Pressure in the head, things like hemorrhages on the brain or strokes, things like that. That causes pressure on the brain.
Just like when with my accident, then they drained the fluid out.
Correct.
Because it wasn't.
And then a recent lumbar puncture that can actually be dangerous to repuncture because that has to have time to heal.
We did a lady, she got her CSF like extracted, and she said that she felt so much better.
Relieve the pressure.
Yeah.
Mm-hmm. And that pressure can cause a brain to collapse if it gets too intense, causing permanent brain damage.
When they do the lumbar puncture?
What's that?
Take out the pressure in the
Yeah.
spine.
Yeah, it can do the same thing. Like the spine can be compressed by the pressure. That can cause, of course, paralysis, numbness, all kinds of issues. Okay, so myelograms. How are we doing on time, guys? Y'all watching time?
10 minutes.
I got
30
10
seconds.
minutes.
Yeah,
5 minutes.
I love all these varying time periods I have. I got 10 minutes, 5 minutes.
I mean, it looks like you
How
know
about 7? Can I get a 7 minutes, 7 minutes, 7 minutes? 7
another
minutes?
40?
Just
Another 40?
Oh, I like that. Another 40. Another 40 sold to the fellow in the white jacket on the middle row. 40 minutes.
Okay, I'll see you at 3 o'clock.
Everyone's gonna jump you.
see me at 3 o'clock, so I'll be out of here at 2:30.
Okay, so myelograms. Seriously though, guys, make sure you know these myelograms, know what they are. Another very commonly asked procedure on the registry that they've been flocking towards because they've just been loving this fluoro stuff. So that's your exam of the CNS structures situated in that vertebral canal, primarily that subarachnoid space that we're illuminating with our contrast. Requires the contrast introduction into the subarachnoid space by spinal puncture. And that puncture is always made at those two locations you see listed there, guys. Make note, those two ranges are going to be your most common. Once again, because it's going to avoid puncturing the spinal cord itself, we're going to be below that termination point of the spinal cord, which was called what, by the way?
Conus medullaris.
Conus medullaris. This is the termination point of the spinal cord. So puncture will typically be made at L2, L3, or L2, L4 is another common space they're going to use. Now, we also have an alternative area if they have like a really bad injury to the lower back, or there's some kind of condition going on that cannot make that puncture. We can use C1, C2, which gives us a little bit more space to work with. It's very close to the brainstem, but the way that the subarachnoid space is situated around that area, it's a little bit wider, and you can just still access that CNS a little easier. Obviously, a lot more dangerous to use that, but it is an option if we need to. That's called an intrathecal injection. That should be a familiar word we talked about way back in patient care. Intrathecal?
Yeah.
Intrathecal, yeah, sure.
That's not the same thing as
Intrathecal.
subarachnoid.
So, yeah, actually, anytime you inject into the subarachnoid space, it's
Last time
intrathecal.
you said intrathecal or subarachnoid.
But, huh? Say again?
At the last time you said.
Intrathecal is, it is. Anytime you go in the subarachnoid space, it is. It
So
is.
subarachnoid is just the space.
Subarachnoid space is the space surrounding the spinal cord. It's like the cavity. The cavity surrounding the spinal cord itself.
The spinal cord.
Huh?
The spinal fluid or spinal
The fluid's in the space that all surrounds the spinal cord. So you have the cord, you have the space, and that fluid is in that space around the cord. So you have like a, it's like it's submerged in fluid essentially inside that space.
So we're injecting beside the spinal cord.
Yes. So yeah, let me reword that. All those injections are considered intrathecal injections, guys. That's a very important term, by the way. That's another registry question. Intrathecal injections are any injection involving the subarachnoid space. Intrathecal. One of those, not fecal, fecal. Intrathecal.
Not intrathecal, intrathecal.
She's bothering you? Stop messing with your sister over there. That's what Lily always complains about too. He's kicking me. Benjamin won't stop kicking me.
Is he really kicking her though?
Yeah. He finds it entertaining to annoy her. Okay, this will usually be performed as an outpatient procedure. It's a walkie-talkie exam. Usually the patient will be held in recovery for this exam 4 to 8 hours, then released to go home. Reason being, you actually have to have the patient sitting elevated for these exams to allow that contrast to drain downwards. Now this is a really great situational question. Why would it be important to have the patient recover for 4 to 8 hours and to have them be erect in the bed? Anybody want to answer that question? That's a situational registry question for you. Why do we have them in recovery after a myelogram for 4 to 8 hours, and why do we have them elevated or erect?
Just like you said, to drain it down.
Fluid doesn't fall back.
To drain down, but what's the danger of it not draining down?
So
Like let's say I lay them flat on their back.
it'll like pull.
Why would it be incredibly dangerous for me to lay a patient flat on their back after this is concluded?
It goes in the head.
It's going to flow back to the head. And we're definitely not going to do Trendelenburg. Yeah, if any of that fluid goes back to the brain, it could actually kill your patients. It actually could kill them if you have that take place. So after myelograms, 4 to 8 hour recovery, and they must always be either semi-erect or completely erect to allow that contrast to flow downward and reabsorb into the body. Like actually can be a life or death situation there.
They're in erect position.
Erect or semi-erect. So either the bed's like their chest is elevated, or they're sitting up in a chair.
So they want the fluid to go down.
You want the fluid to go down. Yes. Going up is dangerous. So gravity's going to pull it, huh? It'll go into the brain and it can actually kill or paralyze you. Yes. So for myelograms, MRI is taking it over, by the way. MRI is becoming the gold standard for myelograms, but we still do these in X-ray every once in a while. If the patient has a contraindication for MRI, things like pacemakers, metal fusion rods, of course myelograms would be your gold standard. Instead of MRI, we want to rip that stuff out of the patient's chest. By the way, my wife's new pacemaker is completely MRI safe. Super advanced, really cool.
Did she feel it?
Like if she was to get an MRI.
I don't think she's ever had an MRI with a device, so
So
that would actually rip it out of her chest. So.
Yeah, that's not like.
now when
Yeah.
you say that it's even safe with these way for the traffic, you know, you go to the security, even safe for that?
So no, that's a good question. It's actually she cannot go through security checks because it erase the data. on her
Or get
device.
one
It would completely shut down the device.
So like if she has to get a
Which that's why what we theorized happened with her having had that last surgery, because we got really close to one of those machines, or she did. We don't know if that's what happened, but we're wondering if that's what messed her device up, made it die early.
So, I don't know if it's a personal issue or like, it goes expensive.
Are they expensive? What do you think?
Like, what I'm saying is they get to put it out of.
They're very any kind of procedure is
Yeah.
horribly expensive. Yes. So she has a dual device. She has a pacemaker defibrillator combination device. It's very advanced. It's wireless. It transmits data straight to the doctor. It's pretty cool stuff.
So she doesn't get Christmas gifts.
That was her Christmas gift this year.
It's life.
Yeah.
Because like one time my mom
It's hard out here.
gate at her house. Like,
Okay.
You're not getting a Christmas gift. I got to the gate. But like this past February, she lost her phone in Vegas. So my dad's like, you're not getting a birthday gift because I have to replace the phone.
Oh, man. All right, guys, we'll end there today.